Good afternoon, everyone. We'll just wait a few minutes for everyone to join. Thank you. Good afternoon, good morning, good evening to everyone. We welcome you all, particularly those of you who've joining far away or where it's late or early in the morning. I'm Supriya Bezbarwa. I lead on EPI-WIN. Thank you for joining this WHO EPI-WIN webinar on Ready and Resilient, Community Social Protection for Preparedness and Response. For those of you who are new to EPI-WIN, it stands for the WHO Information Network for Epidemics, for Science and Knowledge Translation in Health Emergencies. Our goal is to translate the science and evidence in accessible, understandable, and relevant ways for evidence-informed actions and decisions in health emergency preparedness and response. And today, we have a great panel to share with you why community social protection and health emergency preparedness and response matters, and how to include it as part of your work. We have sitting right here next to me, we're privileged to have Dr. Stella Chungong, Director, Health Emergency Preparedness, who will provide the opening remarks. Thank you, Dr. Stella, for joining us in spite of a very difficult schedule. Really appreciate it. We also have with us Dr. Adelheid Marshang, Senior Emergency Officer at WHO, who will provide an overview of the concept of community social protection, and Dr. Sarah Kerman with her from UNICEF, who will also share some examples of how this works in practice. We will then go to the field for the reality of it all. We are privileged to have Jan Grandin, Child Protection Specialist from UNICEF's East and South Africa region, who'll talk about protecting children in public health emergencies and the key learnings from that, followed by Dr. Amar Pen, who's the Health Cluster Coordinator for WHO Ukraine. He'll talk about overcoming financial and access barriers to healthcare in Ukraine and the role of cash and voucher assistance in service delivery. Finally, we have Dr. Kai von Harbour, Unit Head for Community Protection and Resilience. In WHO, we follow the Health Emergency Preparedness, Response and Resilience Framework, where community protection has 3 objectives, of which the third is community social protection. There are 2 others, and he will share with you how this links to the others for overall community protection. Some very quick housekeeping, and those of you who are familiar to EPI-WIN will already know this. This webinar is being recorded, and afterwards the recording will be available on the EPI-WIN website for this webinar. The address will appear in the chat. As always, we love to hear from you, so please, we invite you to post your name, location, and organization in the chat box. We'd love to hear from you and where you're joining. Please add any questions you have on the Q&A box, not the chat box. Although if you have any comments or you'd like to share your experiences, and we'd love to hear your experiences, please add that in the chat. This is your webinar as much as ours. Finally, this is a platform for knowledge exchange for everyone to move forward. So please keep your interactions respectful, positive, constructive, and related to the topic. Anyone who does not follow this will be removed from the webinar. So Without further ado, I will hand over the floor to Dr. Stella Chungong for the welcome remarks for this webinar.
Thank you so much, Chair. Good morning, good afternoon, and good evening to everyone joining us from around the world. It is my pleasure to welcome you to today's webinar on multi-sectoral responses to address the socio-economic impacts of crisis within community protection. We are truly honored by your participation and by the diversity of the perspectives represented here today. Global, regional, national, and even community level actors coming together with a shared commitment to protecting people in times of crisis. Crisis, whether driven by conflict, climate shocks, public health emergencies, or economic instability, do not affect communities in a single dimension. They disrupt livelihoods, strain social cohesion, deepen inequalities, and place the greatest burden on those who are already the most vulnerable. The socio-economic impacts of these crises are often long-lasting, complex, and deeply interconnected with protection risks. That is why today's conversation is so important. Addressing these challenges cannot be done in silos. A multi-sectoral approach, one that brings together protection, livelihoods, health, education, social protection, governance, and community leadership, is not just beneficial, it is essential. When sectors work together, responses become more people-centered, more sustainable, and more capable of strengthening resilience at the community level. Today's webinar provides a valuable space to reflect on how multi-sectoral collaboration can better respond to socio-economic impacts whilst keeping community protection at its core. It is also an opportunity to share lessons learned, practical experiences, and innovative approaches from different contexts, whether at the policy level, in program design, or through frontline implementation. We are especially pleased to welcome participants from different regions and countries, including practitioners, policymakers, development and humanitarian partners, civil society organizations, and community representatives. Your collective experience enriches this dialogue and reminds us that whilst crises may differ across contexts, the principles of dignity, of inclusion, and of protection remain universal. This is also an opportunity for us to learn and to take this approach to scale. Your feedback and suggestions will inform strategic thinking tools and forthcoming documents. As we move through today's discussion, we encourage you to engage actively, to listen with curiosity, to share openly, and to consider how the insights from this webinar can inform your own work. We also invite you to think critically about how multi-sectoral approaches can be strengthened in your context and how community voices can be better centered in both response and recovery. Ultimately, our goal is not only to respond to crises, but to support communities in rebuilding their lives, in restoring their livelihoods, and in reinforcing the systems that protect them. And this is both now, but also in the future. Thank you once again for taking the time to join us today and for your continued commitment to advancing inclusive, collaborative, and protection-focused response to crisis. I look forward to a rich and engaging discussion and to everyone being actively participating in these discussions. I thank you.
Thank you so much, Dr. Stella Chungong, and thank you for your support for supporting our work for multi-sectoral inclusive approaches to health emergencies. As Dr. Stella said, this is an ongoing dialogue, and we would love to hear from you. So before we start the technical part of the session, I'd like to share with you a slide, as usual, our Slido. So if you could just give me a moment for that. So the first question is, if you go to slido.com, hashtag 3529546, it should also be in the chat. If you go to slido.com, hashtag 3529546, or scan the QR code that you can see on the screen. Our first question is about you. Do you currently apply a community social protection approaches in your work? Great. From the responses we get so far, it seems most of you do. We'd love to hear a few more responses though. This 41, 42, 43, numbers are climbing. Come on. We'd love to hear from all of you. There are many, many more online. There's more than 500 of you and right increasing online. So, right. It looks like the majority do, although there is a substantial minority that doesn't or is not sure whether they do or not. For those of you who do, and I hope it's most of you, we'd like to start off by asking you, what do you need in your daily work to apply community social protection better? So please write in the word cloud 1 to 2 words. Again, slido.com, hashtag 3529546. Need training, guidance, interoperability, resources. Now that's big, resources. It'd be great to know what kind of resources you're talking about. Guidance is very important. That's coming up. Training, guidance, experience sharing, maybe like the ones we're having right now, or you'll hear about. Great. Communication, right. Guidance, stronger coordination mechanisms is coming strongly. Great, that's great to hear. Please keep your responses coming through, but in the interest of time, I will now just stop sharing the screen for this one, and we will start the technical webinar. But the Slido is still on, so slido.com, hashtag 3529546. And please go to the first and second questions. We have more questions coming up because we would like to hear from you throughout this webinar. I'm going to stop sharing screen now. And since we've had more than 100 responses, that's fantastic. And I'd like to invite Dr. Adelheid and Dr. Sarah to start the technical session with an overview of community social protection and followed by examples, particularly from UNICEF. So the floor is yours, Adelheid and Sarah.
Thank you, Supriya. Good morning, good afternoon, good day. As Dr. Chung Gong has highlighted, infectious disease outbreaks and crises not only impact health systems, but the broader economy, education, employment, trade, food security, and social stability. These effects can deepen poverty, disrupt livelihoods, and widen economic and access inequalities if not addressed early and holistically. With this webinar, we would like to focus your perspective onto the community level and expand horizons on multi-sectoral interventions to operationalize community level protection. No, previous slide. In emergency preparedness and response, we would like to illustrate using concrete examples from the field how to move towards operationalizing multi-sectoral response approaches for community social protection, putting communities at the center. At the same time, this is an opportunity to learn about gaps and support needs, what is still missing, and how can we collectively do better, and to involve you in contributing to the process of taking the community social protection concept to scale. Next slide, please. Community social protection in the context of crisis refers to coordinated actions and systems that ensure basic needs, livelihoods, and resilience are protected when communities face shocks such as epidemics, those that we just heard, pandemics, natural disasters, or conflict-related disruptions. It includes interventions like cash transfers, food support, social services continuity, livelihood protection, continuity of learning, and equitable access to essential services that help households withstand and recover from socioeconomic impacts. In the context of health emergencies, this means aligning health response with social support programs, for example, for basic income support, food security, continuity of education and community services to reduce harm from both the crisis itself and mitigation measures, such as quarantine or lockdowns or during isolation schemes. The International Labour Organization, the World Bank, WHO have social protection frameworks for emergencies and for the longer term. These are all dependent on multi-sectoral coordination. WHO's frameworks seek to link health emergency preparedness and response and its community social protection component with long-term social protection policies and strategies, a nexus opportunity. In fact, vulnerable and marginalized groups are often excluded from national social protection systems, or these systems are under or not at all developed. This is where surge and or external support come into play too. Next slide, please. Under the health emergency prevention, preparedness, response, and resilience framework for WHO and partners, the HEPR, multi-sectoral action for social and economic protection expands the coordination for community protection beyond health. And this is what we want to focus on today. Equally, on the next steps that we must take to accelerate the implementation of this component at all levels in order to meet the pressing needs of communities affected by and at risk of health emergencies. Multi-sectoral action requires multi-sectoral coordination. Coordinated action needs to prioritize equity, ensuring that interventions avoid creating or reinforcing existing inequalities and are responsive to community priorities and contexts. So aligning health, social protection, education, nutrition, livelihoods, psychological support, and local governance helps mitigate both direct and indirect impacts on communities. It supports equitable distribution of cash and services, helping households meet basic needs and maintain coping strategies without detrimental negative cycles, such as having to sell assets or withdrawing children from school. Next slide, please. And now we're looking a bit at the implementation of community social protection through the multi-sectoral action lens. While multi-sectoral coordination and notions of community social protection is quite well, let's say, is established in humanitarian settings, a more systematic rollout and approach may be required in outbreak management. Implementation needs to ensure precise definition and targeting of the groups for community social protection assistance with participation of all stakeholders, contextualized community social protection packages and a dedicated and contextualized multi-sectoral coordination mechanism. And we can think about if that is all happening. More specific guidance is needed for this type of multi-sectoral coordination in outbreak response, while in the meantime, we may be able to draw from existing examples, and you will see references in the chats that refer to that. Next slide, please. And I'm nearly through before Sarah. Ideally, multi-sectoral coordination. The next slide, please. For community social protection works at the intersection of emergency management, primary care, and community participation, because it translates crisis response into protection of everyday life. It is where rapid response meets continuity, institutions meet communities, and health protection meets socioeconomic survival. Community social protection becomes the operational glue that aligns multi-sectoral action around people's real needs. Because it operationalizes resilience at household level, social protection ensures that emergency responses do not protect health at the expense of livelihoods, but protect both together. Community social protection transforms communities from passive recipients, ideally, into active partners in resilience. And therefore, we can say that multi-sectoral coordination for social protection is where crisis response becomes sustainable recovery, protecting health, livelihoods, and trust at the community level. Over to Sarah. And next slide, please.
Thank you, Adelheid and colleagues. I'm so happy to be here today to discuss UNICEF's experience in community social protection for public health emergencies. Let me begin by acknowledging that the term community social protection can be a bit misleading. I think we've acknowledged that those social protection elements are, of course, included. The interventions themselves are multi-sectoral, community-centered, and in short, they support the community's health protection and well-being. I will provide an overview of why this is so important for children and women, and go through UNICEF's framework for public health emergencies, which is multi-sectoral in nature and community-based. Public health emergencies, both the health threat itself and the response and measures to control it, have direct impacts on the physical and mental health, safety, and well-being of children and women and marginalized communities. These emergencies, as we've heard, can disrupt daily life, affect access to essential services, including health, protection, education, just to name a few, and foster uncertainty and distress. So interventions such as isolation and quarantine can temporarily separate children from their caregivers. Children might lose access to education and learning. The need for mental health and psychosocial support increases from both the health threat and the stress on children and families. And risks of violence, including gender-based violence, exploitation, and abuse, rise. Policy decisions themselves can produce significant socioeconomic and developmental impacts. So this underscores why the best interests of children, women, and the most vulnerable must be central to preparedness and response efforts. Addressing this complexity requires health and social service systems to work together. Most importantly, women, children, and communities must be meaningfully included in the design and delivery of the interventions so that responses are contextually appropriate, equitable, and grounded in their lived realities. Next slide, please. Thank you. UNICEF's operational response framework is aligned with the global HEPR framework that Adelheid mentioned in her presentation, and addresses community protection by acting with governments, ministries, communities, and partners. UNICEF obviously does not do this alone, to interrupt transmission while simultaneously preventing and addressing socioeconomic impacts. We do this to uphold the rights of children and women. We do this, for example, by GBV risk mitigation, such as safety audits of treatment units or water points in communities, ensuring affected children and their caregivers have access to an integrated package of assistance, including nutrition, psychosocial support, and child development interventions, which can also prevent longer-term impacts from the health threat. Providing mental health and psychosocial support for learners, teachers, and education staff through school-based interventions, and continuity of social services to ensure access to inclusive, quality education and learning in safe and protective environments, protection from violence, exploitation, abuse, neglect, and harmful practices, continuity of access to health services, mental health and psychosocial support needs are identified and addressed through appropriate services, including case management and community-based services. And existing social protection mechanisms are maintained and expanded as necessary, including through establishing or scaling up humanitarian cash transfers. We also need to understand the impact of the public health emergency and measures to control it on communities, monitoring children's access to and uptake of services so that we can course correct. This means working across ministries, including health, but also education, water, social welfare, and others. These multi-sectoral interventions under community social protection are not always prioritized in response, as the emphasis is on controlling the outbreak. But the good news, we are getting better, and we're learning lessons from Ebola to COVID-19 and Mpox. Communities, ministries, and the global community have come together with partners to do better, and that, as we discussed, it's in our global frameworks. And now we'll hear examples of how they're implemented in response efforts from our other presenters. I will pass back over to you for the next presentation. Thank you.
Thank you very much, Sarah and Adelheid, for that overview and for sharing with us the examples that you have. We will now go to the field, but before we do that, we have questions for you in the audience. Once more. I see that a lot of you have already found the slide and have shared your responses, but 17 of you, but there are many more attending this, so we'd love to hear from you. Again, slido.com, #3529546. And the question is, what are the biggest challenges to implementing a multi-sectoral response that incorporates community social protection in your experience? And we see some of the issues coming up: coordination, funding, time-bound response, poverty, vulnerability, policy. Well, funding is coming out very strongly. Lack of information and communication and coordination. Coordination is coming up now strongly as we have more responses. We'd love to have some more responses from all of you. There are 50 responses on the Slido, and there are more than 600 of you online. So please share your views. Yeah, coordination and funding, I think, are coming out, and communication are coming out as some of the strongest cross-cutting issues here. As always, I will stop here only for the sake of time for the screen, but the Slido is open. So slido.com, #3529546. Please continue with your responses. We have 88 responses so far. A few more would be great if you could reach even 100. And with that, we go to the field. And I would like to invite Jan Grandin from UNICEF to share his learnings on protecting children in public health crises. Jan is from UNICEF East and South Africa region. Over to you.
Thank you. Thanks a lot. And again, good morning, good afternoon, good evening, colleagues. Thanks a lot for WHO to invite us to share some of reflection. As it was said, my name is Yann Grandin. I'm based in Nairobi. I'm covering Eastern and Southern Africa, and I'm in charge of child protection in emergency. Slide, please. So often when it comes to child protection, we think about, conflict-related protection situation. And while I was working in the western part of Africa for many years, that was our primary focus. But as you can see on the slide, almost all the countries that I'm covering are facing public health events, some of them being emergencies larger scale. And if we can see, thanks to WHO leadership, a very fast response from the health, child protection risk remain largely invisible. The public health emergency do not only create health risk, they increase protection concern, they increase risk of separation of GBVIE, and we will talk about that. They also weaken the child protection system. So, for example, when a child is left alone without parents, when the community is under confinement, then the services are disrupted, then children do not know where to turn to. And finally, and I think that's especially for health colleagues, and we'll see quickly some of the lessons learned. Child protection is not only important for outbreak control, it also improves the quality of what health workers are doing in treatment center. So I'm gonna go to, please, next slide. And my presentation is only for key message, and we'll share at the end lesson learned and best practices documents. Slide, please. So the first message that I'd like my colleagues to keep in mind is that also public health emergency might vary in terms of the death rate or the scale. The child protection risk often remain the same. We have managed over the last 2-3 years Ebola, Pox, Marburg, cholera across the region, but we see the same patterns. We see family separation. So, often people are brought rightly from the communities directly to the health center without any focus on the children. We see GBV. Often girls are left alone, and they, to survive, start to have transactional sex. In Zambia, for example, the main treatment center for cholera was a big stadium. And what we realized as child protection actors is that the girls that were in charge of the people being treated, so to find food and things like that, were living around the stadium. Many of them are to go into transactional sex, or often were victims of sexual violence. There is often, of course, psychosocial distress, and I'm sure you're very, very familiar with that. Slide, please. The second point is that, when we've got a major public health emergency, community system remain essential to the response. First, because all social services, including the health infrastructure, are overwhelmed. Some of them are closing. Social workers might be even threatened themselves or frightened about catching the disease. So communities are at the front line of response. And they often are the only one to offer some services for children. In many contexts, you've got committees, child protection committees, that are in charge of providing that kind of support. They can conduct home visits, so they can go they know their neighborhoods, so they can conduct home visits, see who are the children at risk. They can also provide temporary care. I remember in Burundi during Pox, we had to place many children into their neighboring community. But they also can be a very strong link to help us to identify who are the family the most at risk and who are the ones that are the most in need. There are communities are rapid, they are sustainable, but they one of the lessons is, of course, we need to invest in those communities before the public health emergency happen. Slide, please. The third lesson is that isolation and treatment facilities are high risk protection environment. And I think this message is very important. We've seen that, I remember working on the Ebola outbreak in DRC, where, because of the stress of all the, even the medical personnel that is very infected, and who died, there is a tendency to really try to control the disease without paying any attention to what can be the risk for, as I said, the people that are around the health center, the ones sometimes that are just separated from their family while they are arriving at the center. Often, there are low-hanging fruits. Often, for example, we've seen that the material that is being used to inform people that are in the services to get treatment is not child-friendly. So the children don't understand what is happening. And we've seen that child protection actors can come and support in designing those materials. Of course, SCA, we all talk about sexual abuse and exploitation, but when there is a massive public health emergencies, there is a wide range of actors starting to intervene, and there is a poverty that is increasing and more vulnerability, so that creates those problems. I've seen during the slideshows that funding was one of the main challenge, but WHO is not alone, or other actors can bring this response. What we need is the entry point. What we need is the support of the people that are managing the health emergency to help us to enter and support. Next slide, sorry. The last one is, public health emergency doesn't stop when the health emergency stop. And in many cases, the longer term impact is huge, because you can have, even for a disease like pox, where, people don't really, the death rate is very low. But the fact that people need to stay a very long time in treatment center means that, there's a loss of income. And, many communities where we're working are living on a day-to-day basics. So they are earning the money the same days to feed themselves on the evening. We also see that often families to survive will start what we would call negative coping mechanisms. So, for example, children will be forced to work, and we've seen that in many contexts, like in Zambia, again during the cholera outbreak, where we had so many children suddenly in the streets because they had to find an income for the family while the main breadwinner was being treated. There is also high level of stigma and discrimination. And that's of course impact the families. And that brings me to the last slide. Just moving forward, four key points that I would like you to keep in mind. You need to please help child protection actors to come and support you from day one. And we are also coming with resources. So please do help us to be part of the coordination. Of course, invest in community. That's very important, but I think health colleagues are doing that. View child protection as a life-saving. It's not optional. And if you really want to support the communities, you need to take that into account. And, sometimes public health emergency are also opportunities to build more resilient system. My colleague will put in the chat a link to a more broader, longer document that looks at some of those lessons learned. And thanks again for giving me the opportunity to talk to you today. Thanks.
Thank you very much, Jan. And thank you for shining the light on children, because they're so often invisible And that's a very powerful statement. When health emergencies end, public health emergencies don't end, they go on. And that was Adelheid, actually, since we're in Switzerland, ringing a cowbell to tell you about the time. But now we move on to Amma Pen from Eastern South Africa to Ukraine. Over to you, Amma, to talk about your.
We seem to have lost the sound. Can you hear me?
Yes, we can hear you.
Okay, great. Good afternoon, good morning, good afternoon, good evening, everyone. My name is Ben Amma. I work for WHO in Ukraine, and my role, I'm involved in health leadership, leading partners to respond in supporting the government to deliver health services to the population who are in need. I'm very happy to be with you here today, and I will be using the example of Ukraine to explain how we apply social protection in our own way in the health sector to engage and address barriers accessing healthcare. Next slide. Thank you. So we all know for over 4 or 5 years now, Ukraine has undergone the large-scale invasion, and at the moment we have about 3 million people displaced out of a population of 41 million. There are very, very frequent attacks, meaning that in the frontline locations, access to healthcare is actually constrained by the lack of access to services, healthcare workers not being available, and destruction. Maybe before we go on in the presentation, I'd just like to highlight that the Ukrainian government usually provides healthcare services free of charge to all the population through a national health service unit that purchases the services from service delivery points, that is hospitals, and that the Affordable Medicines Program also ensures the provision of medicines free of charge to every citizen. In frontline locations, we face the challenge of access due to the destruction and the barriers that come in place as a result of the war. Next slide, please. So following the awareness, following assessments, multi-sector assessments that have been conducted by health protection actors and other stakeholders, Ministry of Social Policy and Ministry of Health, we identified clear needs for people accessing healthcare services, and different partners have been playing the role of engaging to ensure that those who are vulnerable, people who are above 60 years, people who have limited mobilities, people who live with disability, children, pregnant, lactating women can access healthcare services. And we can see that the impact of the war is also documented, and this has also been identified. Furthermore, certain attempts on use of multi-purpose cash to actually provide services has also come with challenges around accountability, around health risk for those who actually go seeking the services themselves, because using out-of-pocket payments only makes them put in more money and not actually having quality services in the end, but also that the health system could be disrupted down the line in terms of the balance and equilibrium ensured by the government in this right. Next slide. So with regards to this and following the evidence, following all the challenges in place, the coordination, WHO, health partners, protection cluster, Ministry of Social Policy, Ministry of Health came together to reflect on how to address the issue. And for over 3 years now, we've actually come up following the assessments with some guidance. And through strategic documents, we've been able to clarify how we can address the different barriers in terms of access to locations through transportation, because it presents itself, because barriers of medicine, availability of the medicines presents, access to consultation services, access to laboratory and diagnosis, access to rehabilitation service, and sexual reproductive health services. So in terms of our strategies, and activities, we have established clear linkages between the response plan at the national level, but equally national health action plans that exist, and also action plans that exist within the Ministry of Social Policy. So the addressing of these barriers relies on this, and there is a lot of communication in terms of line of flow of the patients across the different departments to ensure that the needs of these barriers are lifted on time. Next slide, please. So basically, how is it done? We have service delivery at the service delivery points, which is the health facility, which is being reinforced. But on the other hand, we have the communities, we have the protection cluster, we have the Ministry of Social Policy, and we have the Ministry of Health. So there is regular coordination at the local level, but also an established referral path between the different sectors, ensuring that once persons facing the barriers are being identified, they are being channeled through and referred accordingly. And this is also made in a very clear and established way through a dashboard that is put in place. The services that are being provided complement the National Health Service Unit packages, which are available and declared by the Ministry of Health. And just to let you know, meeting protection needs, social protection needs doesn't mean that we have to go about disrupting the system. We identify locations where these are substandard, where there are no program of medical guarantee services in frontline, where there are no medicines in frontline, and through an assessment, we establish this, and this is how we go. And we use very clear vulnerability criteria to establish who is going to receive this and to ensure that the modality which is being used, be it a cash, reimbursement, or vouchers, are being applied accordingly. Next slide, please. So for over 4 years now, we've been doing this, but for last year, I would like to present some achievements just for you to know. There has been a clear framework that establishes how to identify the barriers, how partners can go about this, how partners can engage in the planning, and what are the standard operating procedures to engage in. And in terms of identification, in terms of indicators and monitoring, this has been clarified. And health protection, Ministry of Social Policy, Ministry of Health, we can clearly, at the end of the year, also identify how much progress we've made based on benchmarks which have been set up from the start. In terms of referral, counter referral, this really stands out, and this is one big area because once needs are identified at protection, they can be sent to health, they can be sent to the Ministry of Social Policy, and also there is increments in terms of the government awareness to reinforce its social program, and this is where it really comes in as an advantage. So you can see here about 31,000 people reached, vulnerable people, to be more specific, receiving assistance in this kind of way. And you can see the amount of funding that was earmarked only for the use of cash and vouchers in 2025 alone. In terms of challenges, there exist many, but as time goes, partners would reflect on how to address this. In terms of, they present themselves in terms of weaknesses, in terms of referrals in some locations in frontline. Remember, it's hard to reach context and in the frontline, and this is where the focus is, and partners have to reflect each time and share information. And this is where the use of the dashboard becomes very useful. The next part of it is with regards to coverage. Not every partner is present everywhere. So partners have to be flexible, and also donors have to also accept that flexibility in terms of their funding to be able to allow them cover more ground and to also move as the front lines also are dynamic in that sense. Another challenge is the lack of supply side intervention. So when we talk about the use of cash and vouchers, you have to think about somebody needing a service and also another person providing the service. So looking at the supply side, you think about the different aspects: consultation, laboratory, rehabilitation, and all of that. So we don't always have all the services available, and we have to think about how to address this. Sometimes partners will go provide. Sometimes we have to rely also on the private sector, and the role of the private sector has also been very instrumental in bringing this to light. So the interaction between the different stakeholders, health, protection, private sector, Ministry of Health, Ministry of Justice, has been instrumental in ensuring that the barriers are also lifted. And we have challenges with regards to power sometimes, and this also makes it difficult ensuring the referral and counter referral. And we kind of use other means to be able to address this. Next slide, please. So in terms of reflections way forward, we see a few things. They stand out here. Complementing existing systems, it's always important to reflect on what's on the ground, to reflect on the status quo. What are efforts of the government? What's the effort of the Ministry of Social Policy to ensure that you implement in ways that complement and don't disrupt? The flexibility of the partners, of the leadership, of the strategy is always important, because as time goes on, governments reflect and improve on their strategies to ensure and improve social assistance to citizens. So this adaptation is always required to make sure that the interventions are streamlined and better targeted rather than disruptive. Using evidence is always helpful to inform decision making. So prior assessments, be it multi-sectoral, but looking at it from different perspectives would always help ensure that the quality is good. And community engagement is key. And the final message, which I would like to give to everybody, I saw in the questions, was the lack of coordination, the lack of finances. But I would say the main thing we can take from this presentation is the initiative. The program manager, the head of the organization, the implementer, and everyone can engage in their own way to make sure that they can do some part of social protection work. I think this is the message we should take, be it very small, and we can then build from that and work across the different sectors. Thank you, and over. And back to you.
Thank you so much, Amma. Thank you for that presentation and very important points. The importance of taking the initiative and implementing CVA to complement national systems. That's important. Then now we go to the Q&A section, but before that, you can see that this set of panelists really want to hear from you. They have another question for you through Slido. So here we go. And I see that some of you have already started answering. Now the question is more specific. What are the barriers to implement community social, to your ability as an organization or individual? It's more personal and specific now, to implement community social protection. And again, its funding is coming out as a huge issue. It's by now you all know it. It's slido.com, hashtag 3529546. You probably know it by heart by now. We'd love to hear from you. Okay, I can see that funding remains, finance allocation and legal restrictions are some of the key issues here. As the Slido's open, I'll stop here for now. And before the Q&A session, I will hand over to Adelheid. You've heard the situation in the field, but we have some concrete examples now. And over to Adelheid. Michael.
Yes, thank you, Supriya. Indeed, we have put together on a slide a number of other examples that we know from the field. I also have to say that examples from the field are usually shared as experience, and to get holistic documentation is quite a challenge. So we have put together just a few, and maybe if you have published experiences and such documentation, kindly paste them in the chat. We will highlight them on the webinar website. And of course, we will also work with them, because as Dr. Stella said, this is a dialogue and a discussion, and it's actually quite exciting because we see that we are on the same page. We hear some of the key issues that are coming out, and they are super valuable in moving this work forward. In the further contexts and examples of community social protection and community engagement, the slide will be up there very soon. In epidemic response and humanitarian conflict settings, we are looking, of course, at acute and prolonged contexts. And you have heard already from Jan on the outbreak situations and the specific child protection challenges there. We have cash assistance in and social protection in conflict settings. And so Penn's, actually, Dr. Amma Penn's presentation was a key example. In addition to that, in humanitarian settings, I don't want to mention UNFPA cash transfer for sexual and gender-based violence programs, which are an important and absolutely crucial component in humanitarian settings, but of course also in outbreak situations. I also want to remind that longer term situations, like for example, the HIV outbreak or pandemic, if you will, have documented very, very important experiences of social protection interventions that include cash transfer, food assistance, education support, access to healthcare, and whereby improving living conditions and the economic opportunities, social protection was able to, that was proven, reduce the risk of HIV infection, of course, the ultimate goal, also directly addressing poverty and inequality, which are key drivers of HIV transmission, but also the key drivers of other outbreaks. And finally, before this slide comes to end, I just wanted to reference that there are studies from the Sahel and other regions which underline that formal social protection, when we want to talk about systems that we are complementing, must be complemented by community social networks and informal mechanisms such as mutual aid, kin support to be effective, especially where formal systems are weak. And my colleagues have mentioned that already. Indeed, we need to work together, put the hands together, and hopefully we can, nobody is alone, as Jan said, we're not alone, but in working together, we can also achieve cost-effective synergies. Back over to Supriya.
Thank you very much, Adelheid, for those examples. And the links are, these slides, of course, will be shared on our website, and the links are also on the chat. Before we go to the Q&A, our unit head for community protection and resilience, unfortunately, could not be here today, but he's recorded a video to talk about how the two objectives of HEPA linked to the third objective, multi-sectoral action. As you may be familiar, the Health Emergency Preparedness, Response and Resilience Framework has community protection as one of its subsystems, and community protection has three objectives. The first is community engagement and risk communication. The second is population environmental interventions. And the third, which we're focusing on today, is multi-sectoral action. But how can the other two interact with the third? For that, we now have the recording by Dr. Kai von Harbu.
Thank you very much, and apologies I can't attend this very important webinar in person. I would like to briefly reflect on what you have discussed in today's meeting from a community protection perspective. The main message we want to share on this work stream is that public health measures do not operate in isolation. They interact directly with people's livelihoods, their social obligations, and their ability to meet basic needs. And this is why multi-sectoral action for social and economic protection is positioned as the third objective of community protection under the Health Emergency Prevention, Preparedness, Response and Resilience, or HEPA framework. Under HEPA, community protection brings together three core elements that must function together: risk communication, community engagement, and infodemic management, population and environmental health interventions, and multi-sectoral action for social and economic protection. These are not parallel tracks. They are mutually reinforcing. And when one is missing, the others struggle to deliver impact. What we often see in emergencies is that people receive and understand health advice, but they cannot act on it because they live from day to day, and asking them to isolate to stop working or to change daily practices can mean losing income, losing a job, or not being able to provide food for their family. In these situations, non-compliance is not about misinformation or lack of trust. It's about meeting basic socioeconomic needs. This is why these considerations are so important to make health guidance feasible, equitable, and credible. Cash assistance, food support, access to childcare, and social care services are the enabling conditions that allow people to comply with public health measures without resorting to harmful coping strategies. These measures reduce transmission risk, but they also reduce fear, stigma, and social harm, and they help maintain trust in institutions and protect social cohesion during crisis. This is what we want to achieve here: systematic mechanisms that work in practice to enable health actors to work together with social protection, education, livelihoods, and humanitarian partners to align the response activities with the realities on the ground. And this is not only about response. This needs to be integrated into preparedness planning to reduce the need for ad hoc solutions. I would like to thank our colleagues at UNICEF for the excellent collaboration on this agenda. Thank you very much, and I look forward to the continued discussion.
That was Dr. Kai von Harbu talking about all three objectives of community protection. And with that, we go to your Q&A section. So all the questions you've written in the Q&A, we hope to address them through our speakers. So please, if you have any questions, please put it in the Q&A. Right. The first question, well, there are thanks to all of those of you who've been thanking us. I'm glad you find the webinar useful.
So on the Q&A, we have identified, of course, who is going to answer to some of them. And
I'll be happy to start with a few responses if you want.
yes, please go ahead.
Yeah, thank you. Thank you. Sorry. Thanks again for the many questions, and we keep putting resource documents on the chat. There was a question from, I think, Nadira Sultana around how does the UN can support the system and the government. And I think that's exactly at the pinpoint of the discussion is, I mean, while in some emergency, the government might not have the coverage, and that we need to also build on communities. I mean, the different UN agencies are definitely strengthening the government, and that's, in terms of preparedness and response by, strengthening their capacity, finding what are the, we do, for example, with UNICEF, organized by WHO, after response review, which involve the government, and that help us to better prepare for the next response. There was a question on PSEA. I'm not fully sure, but I think the question was around how do we protect not only the communities, but also the personnel on PSEA. I'll put on the chat a specific resource that we have developed on PSEA during public health emergency, and how do we make sure that we convey the right messages, that people have access to helpful and useful complaint mechanism, and how do we strengthen also the capacity of the different actors. Yes.
Thank you. Yes,
Thank
super. Fantastic. And thanks for highlighting all the resources, colleagues. Everyone has been chipping together and shared resources. There is a real wealth of them in the chat. In terms of the question regarding the questions on interactions with trade control systems, great question from Shiva. Apologies if I mentioned the first name. There is a framework, a multi-sectoral framework for coordination on preparedness. The link is pasted in the chat. you may find answers in that framework. And of course, we're also happy to address remaining questions by email online. Over to Pen for the question you wanted to answer.
Okay, thanks, Adelheid. I see here there is a question from Muhammad Usama, who asks about how do we transition a community from absorptive capacity to adaptive capacity without causing protection gaps where households lose their safety before they are truly self-reliant. I think for this one, we have to reflect from the outset. For every transition to be effective, it's important that whatever actions in terms of strategy through implementation are done, taking cognition of national capacity and efforts. And I think also it should reflect policy, meaning national action frameworks that exist. Being done this way ensures that actions are better aligned and don't deviate from what the different ministries would want, but equally that there is some preparedness or reflection on a phase-out process. And this would require program managers, donors, and implementers to reflect in this regard and come up with probably a phase-out process where different steps are being implemented to ensure that the transition is smooth and seamless. I think this is how we can address it. Thanks a lot, and back to you, Adelheid.
Thank you so much, Pen. Great. And now over to Sarah.
Thanks, Adelheid. I think many of the questions are answered, and some of them are still open. Agree. There's just a lot of comments, I think, now in the chat. We've answered most of the questions. It's true that there's a lot to learn from population health and protection. I think the point is that we can all learn from each other and to make sure that the development work is part of our preparedness so that we're better placed to respond. And I think that's where that linkages come in. So thanks for that comment in the Q&A.
Wonderful. Thank you, Sarah. And we will move to the end. We have for you, as you had for us, we have for you some take-home messages that we're going to project next. And we are really delighted, as I mentioned, by the take-home messages that you had for us through the Slido. And we may see that actually we're on the same page. And while we wait for the slide, the next one, please. Yeah. So, no, the previous one. Yes. These are the take-home messages, and you will see it going through them that we have identified similar points. And therefore, I think we can, in congruence, move forward because coordination, guidance, tools, funding is exactly, but when we talk about coordination, it's not the absence possibly, or if it's the absence, maybe we can help through guidance or some operational notes to help inform the elements that multi-sectoral coordination in such situations should entail, and that broad stakeholder commitment, as we have also learned here, is super important. It needs to include all the levels. I want to point out also municipal levels. They're super important, as the community levels, of course, women's groups, people living with non-communicable diseases, adolescents, people with disabilities, as we could see in some of the examples, to strengthen the linkages between health, other social services, local governance, to share data, target support. Targeting is really essential, and scale assistance quickly and ensure the continuity of these services. So coordination, continuity are super important factors. Using anticipatory action, leveraging existing community structures and informal networks that exist already. Next and final slide, because this is now really for you. What can you do? after this webinar, and of course in the process that we are in, to really consider the community perspective throughout the emergency management and planning cycle. We need to get closer really and work much more with the people that are affected, to have community social protection and information on vulnerabilities, key target groups for social protection in strategic preparedness plans, humanitarian response plans from the outset. Because many have talked about funding. To access response funding fast, one has to be fast in the early response, and to have those things already ready. It's important to tailor these stuff, if I can say, community social protection packages or coordination mechanisms, to discuss that before, integrate it into preparedness effects ahead of time. And so I think possibly we will come back with another webinar on this and see how we would be doing with some of the guidance that may be coming out on sectoral coordination, on the continuity of community services. And just want to finish by saying, quoting one of my colleagues saying, we're not alone. We just need to join forces more. Guidance, tools, and effective coordination, and we can maximize the use of costs. Back over to you, Supriya.
Thank you very much, Adelheid, and a huge thank you to all colleagues. Now, this is not the end, though. We're coming close to the end, but we have one more question for you. As Adelheid said, this is the beginning of a dialogue, and that dialogue for today ends with knowing from you what further tools or guidance for implementation is needed at the country and community level. I see one participant. I know if we're over time, so thank you for those of you staying on, but we would still love to hear from you. And the Slido will be open for another couple of days, so if you have further inputs, please do share. And while we're doing the Slido, I would like to take the opportunity to, first of all, thank all the speakers. They've spent a lot of time. There's a lot of good work being done, and they've taken the time and trouble, in spite of working in emergencies, to share those experiences so that we can all benefit. So huge thank you to you. Thank you to our director, Dr. Stella Chungong. She's been consistently very supportive, and we're very grateful. I'd like to thank our interpreters and our IT support there as well. We often start off panicking before EPI-WIN webinars, but then they smooth everything out, so we're very grateful. Also, working in the background, we have, maybe you can see them in the room, Michael and Armora. They've been working in the background, doing the flyers, sending the invitations out so that you can join this webinar. Huge thank you to both of them for a lot of heavy lifting in the background. And finally, also, Kanika and our colleagues from Project ECHO, our partners for EPI-WIN. Thank you, Kanika, for your support in this webinar, and also to all the others from Project ECHO. But last but not least, all the participants. I can see many of you have left, but then there's still more than 400 of you here. We're very, very grateful. EPI-WIN is EPI-WIN because of you, because of your engagement. And really, this is for sharing knowledge for everyone to benefit. So we'd love to hear from you. As I said, I will now stop sharing the Slido, but it's open. So please continue to give your feedback here. We can see capacity building and training guides. Capacity building is coming really strongly. Funding, of course, these are the times, so funding is always an issue. Technology, interestingly, that's interesting and important in the more connected world. with that, for now, I stop this, and I want to let you know that next week we will be having 2 EPI-WIN webinars, and I had my screen right here. I wanted to share it, and I don't know where that's gone now. Can you see? So next week we have 2 EPI-WIN webinars. One is on Monday. This is to align with 10 years since the first public health emergency of international concern being declared for Zika virus disease. And then on the usual Wednesday, we have an update on seasonal influenza. Especially, there will be a focus on some of the new variants that have come up this year. So please do scan the QR code. You will be seeing the flyers and be receiving the invitations as usual. Please also check your spam in case the invitation sometimes goes to your spam. We've had a few people tell us that happened, so do check your spam. I do hope you will join us next week. And with that, thank you for your patience. We're 15 minutes over time, so we will stop here for now. Thank you very much. Yeah, love the emojis coming up. We love having you too.
So nice.
And thank you to all the speakers for staying on 15 minutes over. And the interpreters and IT colleagues.